Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from F. Hoffman LaRoche Limited.
Hello everyone, I'm Peter Schmidt. I'm a medical oncologist and professor of cancer medicine at St. Bartholomew's Hospital in London, United Kingdom. I would like to welcome you all to this program titled Clinical Perspectives on the Use of PI3K AKT pathway inhibitors in the management of ER-positive, HER2-negative metastatic breast cancer. It is my pleasure today to be joined by fantastic faculty Frédéric Pinot-Loca, Professor of Pathology at the Jean Perrin Comprehensive Cancer Center in Clermont-Ferrand, France, and Professor Kevin Kalinske, Director of the Division of Medical Oncology at the Emory University School of Medicine in Atlanta, USA. The treatment of metastatic ER-positive, HER2-negative breast cancer is very well described. We will always try to offer patients endocrine treatment when we can. We make a distinction in the choice of endocrine treatment. All the guidelines show this as well, depending on whether patients have disease recurrence whilst on endocrine therapy or after they stop their endocrine treatment, or if they have de novo metastatic disease. And this is to distinguish and separate patients who may have endocrine sensitive disease from patients who have already some form of endocrine resistance. In patients with endocrine sensitive disease, which is defined as de novo metastatic breast cancer, or patients who have disease recurrence more than 12 months after they stop their adjuvant endocrine treatment, we would generally consider aromatase inhibitors and CDK4/6 inhibitors as the standard of care in the first-line treatment setting. But when patients have disease progression and we want to proceed with second-line treatment, it has now become standard to test for somatic mutation, either based on tissue or on a liquid biopsy, to see what is really driving that resistance of the tumor, and then select second-line treatment strategies depending on the mutational profile. If you look at patients who have some form of endocrine-resistant disease, defined as patients who have disease recurrence whilst on or within a year of ending adjuvant endocrine treatment, in these patients it's really important to assess the PIK3CA pathway status, to look for PIK3CA mutations. If patients have an evidence of a PIK3CA mutation, we can offer them a combination therapy of endocrine treatment with a CDK4/6 inhibitor and a PI3K pathway inhibitor called inavolisib. But of course, patients could also be considered here for a doublet with CDK4/6 inhibitor and endocrine treatment. If patients don't have a mutation of the PI3K pathway, we would again, similar to patients with endocrine sensitive disease, consider a combination of fulvestrant and a CDK4/6 inhibitor. Similarly to the endocrine sensitive situation, when patients progress on first-line endocrine treatment, we would perform mutational testing based on tissue or liquid biopsy, and then select subsequent treatment strategies really based on the mutational profile. Second-line endocrine treatment is largely guided by how patients responded to first-line treatment, but also to the mutational profile we may be seeing. If we find mutations in the PIK3CA and PI3K AKT pathway, either by mutations in the PIK3CA gene, AKT, or PTEN alterations, we can consider combination with an endocrine backbone, usually fulvestrant, and then either an AKT inhibitor in the form of capivasertib or a PI3K inhibitor of alpelisib. If patients develop or have an ESR mutation and have had a relatively long benefit of endocrine treatment, we can consider targeting this ESR1 mutation with an oral SERD such as elacestrant. If patients have neither of those mutations, an effective strategy is to switch, for example, to a different CDK4/6 inhibitor, but also bringing other drugs in, for example, everolimus in combination with either exemestane or fulvestrant could be an option. And in patients who have BRCA mutations, we have also an opportunity to bring in a PARP inhibitor. For once patients progress on second-line treatment options, again, the clinical question is there a benefit from further endocrine treatment? This is clearly driven by the response to first and second-line therapy, but also by information on mutational profiles. And again, it makes sense if patients hadn't got an ESR1 mutation prior to that to test for ESR mutations at this point in time. Now we want to focus a little bit more on the PI3K pathway today. And I would like to bring Friederike in, please, if this is possible, to really talk us about the pathway and the rationale for targeting the PIK3CA PTEN AKT pathway in clinical practice. Friederike, over to you.
Thank you, Peter. So first of all, to set the stage, let's anchor on the biology that drives decision making, and then later I'll translate it into a practical testing pathway. In hormone receptor positive HER2 negative breast cancer, the PIK3CA PTEN AKT axis is the central growth and survival pathway. PTEN restrains signaling. PIK3CA and AKT activate it. So knowing the precise lesion along this axis will help us to anticipate who will benefit from PIK3CA AKT inhibitors. So now let's zoom on the keynotes, starting with PIK3CA. So PIK3CA is an SCAT1A biomarker with hotspots in exon 7, 9, and 20, with some of the alterations in bold that are the key variants. Roughly 40% of ER-positive, HER2 negative tumors will carry a PIK3CA mutation, and they are often luminal A. PIK3CA mutations are not exclusive from the other gene alterations, such as ESR1, and we know, for instance, that the patient with PIK3CA mutation, that they can derive a clear benefit from PIK3CA inhibitors. The double PIK3CA mutation in cis occur in about 12 to 15% of the PIK3CA mutant cancer. They hyperactivate the pathway, and they are particularly sensitive to PIK3CA alpha inhibition. They are like our super responders. Now from PIK3 to its downstream effector AKT. So AKT1 E17K is an SCAT1/2 biomarker. It is a bona fide cancer driver that is present in approximately 2 to 7% of breast cancer. Clinical data, including Capitello 291 and NCI match, show that capivasertib activity is important here, and AKT was tested by NGS. So in practice, we should test AKT1 when the drug is available. And then completing the circuits, we go to the brake. So PTEN. PTEN is a pathway brake, so it has to be inactivated. And capturing the inactivation of PTEN is complex because we have diverse genomic events in inactivating mutation around 7%, and we have no hotspots, so we cannot select hotspots by PCR. But we have also possible epigenetic silencing and immunohistochemistry readouts, and standardization is ongoing for PTEN, especially with the prostate cancer experience. So when considering an AKT inhibitor, and when you want to identify genomic PTEN loss, we need to pre-authorize NGS in this setting. So before we shift gears to clinical trials targeting PIK3CA pathway, I have two messages. Don't forget the other important biomarkers that Peter specified to get in the hormone receptor HER2 negative patient group, ESR1, HER2 low and ultra low, and if not tested before, germline BRCA1 and BRCA2 mutation, and also to germline PALB2 mutation. And PIK3CA, AKT1, and PTEN together, they shape who benefits from PIK3CA AKT blockade. So the biomarker for eligibility will depend on the treatment line and also on the drug, whether it's a specific inhibitor or a pan inhibitor. And with that, Kevin, the floor is yours.
Thank you, Frederic. Fantastic oversight. It's clearly an essential multinodal pathway. And we will come back to some of the testing aspects in a minute, but I would like to bring Kevin on board now just to talk us through some of the clinical data of agents targeting PI3K or AKT, which are already approved and in regular use. Kevin, over to you.
Sure. Thanks, Peter. So I'm going to talk about some of the pivotal studies that have led to the approval of these agents in treating our patients with metastatic ER-positive disease. So the first one, and Peter had alluded to some of these data, this is ANAVA 120, which is a study in a very specific patient population. So these are patients who had PIK3CA mutated, hormone receptor positive, HER2 negative disease that had recurred on their adjuvant endocrine therapy or within 12 months of completion of that. So patients who had demonstrated some endocrine resistance, and these patients had measurable disease. This is a frontline study. Also, it's worth noting that patients needed to have a fasting glucose that was less than 126 and a hemoglobin A1C that was less than 6. And patients were randomly assigned to receive triplet therapy, inavolisib, which is given as a daily drug, plus palbociclib and fulvestrant versus placebo, palbociclib and fulvestrant. So triplet versus doublet. And the primary endpoint was progression-free survival. And we saw that there was a nearly 10-month improvement in progression-free survival. I want to point out on this slide really how poorly patients seem to do if they were getting the doublet. You can see the steep drop of patients where they are having progression of their disease, and that just the difference between the two curves. And then we also saw an improvement in overall survival. The data have been published in the New England Journal of Medicine originally, and then there was an update as well. And we saw that there was a 7-month improvement in overall survival. And this was the first time that we saw an overall survival advantage with a drug in this pathway. So what are the side effects that we can see? Some of those that are listed here are really due to, for instance, the CDK4/6 inhibitor, where we can see neutropenia. One can note the rates of hyperglycemia and diarrhea. The most of those tend to be lower grade. There is a risk for stomatitis. Again, most of those are low grade, but it is worth thinking about. And if you're starting a patient on this regimen, if you have access to giving an oral steroid rinse for prophylaxis, that can be helpful. There also was a risk of low-grade rash as well as some ocular toxicities. So the next study is Capitello 291. This is a different population. So these are patients who have received no more than 1 line of chemotherapy, no more than 2 lines of prior endocrine therapy, and they could have had tumors that had recurred on or within 12 months of their completion of adjuvant endocrine therapy, but it is worth noting that a good proportion of these patients had received prior treatment in the metastatic setting. I also will note that the hemoglobin A1C cutoff here was a little bit different. It was 8% as compared to what I just mentioned from ANAVA 120, which was 6%. In this study, patients were randomly assigned to receive fulvestrant plus placebo versus fulvestrant plus capivasertib. So just to mention, capivasertib is a AKT inhibitor, and in this particular study, patients could have had either a mutation in PIK3CA or AKT or an alteration in PTEN. The study primary endpoint was the dual primary endpoints of progression-free survival in the overall population, as well as those who had alterations in the pathway. So when we look at the overall population, you can see that there was an improvement of about 4 months, but really what had seemed to drive this benefit was patients who had alterations in the pathway, where you can see a difference of 7.3 months compared to 3.1 months. And what we saw with overall survival, I just want to highlight with the AKT pathway altered population, the number of events are limited, and you can see that the arms still do display. But again, the primary endpoint was progression-free survival. In terms of toxicities that we can see, there is risk of gastrointestinal issues like diarrhea. One can see rash. I do want to note hyperglycemia, where again, the majority of those tend to be low grade. The rate of stomatitis, if we were to do some comparison with another 120, is a little bit less. Also, one needs to monitor things like liver function abnormalities. And just to continue, I wanted to briefly mention the EPIC B5 study. So this was a study, again, that looked at patients with advanced hormone receptor positive HER2 negative disease as compared to Capitello-291. In this study, patients needed to have received, have a PI3K mutation and have a tumor that relapsed on or after a CDK4/6 inhibitor and an aromatase inhibitor. So this study is a little bit different than SOLAR-1, in which there was a smaller proportion of patients who received a CDK4/6 inhibitor. And in this study, all patients must have received a prior CDK4/6 inhibitor. And in this particular study, patients were randomly assigned to fulvestrant plus alpelisib versus fulvestrant plus placebo, and the primary endpoint was progression-free survival. There was crossover allowed as well. I just want to mention, you can see here the improvement in progression-free survival. And then if you look at overall survival, you can see the displaying of the curves as well. There was a numeric improvement in survival in this particular study. So I will say it is worth noting the toxicities, hyperglycemia, rash, the rate of having higher, grade 3 or higher hyperglycemia is more with alpelisib than what we see with other agents. And also just to note the rash as well, which can include more than 10% can have grade 3 or higher rash.
Brilliant. Thank you, Kevin. That's really helpful for the existing drugs. I can maybe take over and talk about a couple of trials that sparked some discussion after ESMO 2025. New randomized trials. These are not necessarily approved in this combination, but I think it's worthwhile just setting the scene here that we can use this maybe in the discussion. One was the Victoria 1 trial, and it almost felt like a loop back in time, because the last few years we have spent on finding more specific PI3K inhibitors or AKT inhibitors, but here was a drug that's a combined PI3K mTOR inhibitor, so it hits the top and the bottom of the pathway, a drug called gedatolisib, and it was in there are two trials ongoing. The trial that was presented, study 1, looks at patients without PIK3CA mutation, and it's a 3-arm trial, fulvestrant as the endocrine backbone alone, or fulvestrant as a doublet with gedatolisib, or then the triplet with gedatolisib and palbociclib, looking at progression-free survival. Now, one of the things that is important when we look at the results is also this is not an orally available PI3K kinase inhibitor. It's an intravenous drug that's given weekly, 3 weeks on, 1 week off, and I think that is important for patient acceptance and how we look at those data. Just very briefly through the trial data, the triplet versus single agent therapy, significant and meaningful improvement with a hazard ratio of 0.24. If you look at the doublet versus single agent, the doublet meaning gedatolisib fulvestrant versus fulvestrant, again we see a hazard ratio of 0.33. But what we obviously already know is that everolimus as an mTOR inhibitor in this setting has also shown a substantial improvement compared to fulvestrant alone, and it will be up to the future to really see whether this drug will add to our treatment armamentarium in this setting. And another trial I personally found really interesting is the Evera trial, and that is a randomized trial where both treatment arms contain a targeted agent with everolimus, but what has changed here is the endocrine backbone. And I think as a concept, that's really interesting. So patients with prior endocrine therapy, up to 2 lines of treatment, who had progression after CDK4/6 inhibitor, were randomized to either standard endocrine treatment, which could be exemestane, fulvestrant, or tamoxifen, in combination with everolimus, or in the experimental arm, giredestrant, which is an oral SERT compound together with everolimus. And as such, we know obviously from studies that in patients, for example, with ESR1 mutations, if we switch to an oral SERT, this can have advantages over standard endocrine treatment, but we have never really seen this in the context of a second of a targeted agent. Now, if we look at the PFS data, progression-free survival data in this trial, a significant benefit, and this is in the ITT population that includes patients with and without ESR1 mutations. We see a significant improvement from 5.4 to 8.7 months, hazard ratio of 0.56. And again, safety profile is interesting because it's largely obviously driven by the targeted agent and ultimately relatively little difference between giredestrant and standard of care endocrine treatment. And I think this makes it interesting for us to await the first line data we are seeing with oral SERTs versus standard of care endocrine treatment in the context of CDK4/6 inhibitors. Now, there's a few trials ongoing, and Kevin, maybe I can bring you back in to talk us through what we are hoping to see in the next few years targeting this PI3K AKT pathway. Kevin.
Sure, thank you. So I just want to mention a few studies. One, you can see the first study listed here, NAVA 121. This is a completed study that it's the first time that we're really seeing a comparison between two PI3K inhibitors. So this is for patients who've had a tumor that has progressed on a CDK4/6 inhibitor endocrine therapy, comparing fulvestrant plus inavolisib versus fulvestrant plus alpelisib. Hopefully, we will see these data soon. Also, there's the Rediscover 2 study. So I do want to mention that increasingly there's interest in even more specific inhibitors that may not only be efficacious but have less associated toxicities. And so this is a study that is comparing a more specific PI3K inhibitor plus fulvestrant versus capi plus fulvestrant, and then also Capitello 292. So this is looking at triplet versus doublet, very similar population that we talked about with the NAVA 120, but in this particular circumstance, instead of giving a PI3K inhibitor, patients would be randomly assigned to receive the AKT inhibitor capivasertib.
And we would hope to see that with the results of this trial, we can really optimally position the inhibition of the PI3K AKT pathway in the first and second line setting in doublet and triplet combination therapy. And I think that will ultimately take us forward to allow us to optimally utilize the power of targeting this pathway in patients with ER-positive, HER2-negative breast cancer. Now, I would like to move us to some of the clinical implications. And one of the key questions, we touched this very briefly at the beginning, Frederic, is how do we actually test for PIK3CA or for pathway alterations in clinical practice? What are the best sample materials? And there's no one better placed than you, Frederic, to talk us through this.
Thank you. Yes, having all those clinical results in mind, we now need to look at what type of samples should we use, what should be ordered, which testing approach, and when should testing take place. So first of all, the sampling sequence. Ideally, we need to test the metastatic lesion, so it can be tissue or liquid. If you need a rapid read or if tissue is limited, you can start with ctDNA assay. And if ctDNA assay is negative, reflex to tissue to avoid false negatives at low tumor fraction. So this mirrors INAVO 120 testing strategy, where 92% of the tests were ctDNA based, and it aligns with my own workflow. That's what we do in our clinical practice. So why metastasis and not test the primary tumor? Because when tissue is tested, there is a 10% discrepancy in PIK3CA status between the primary tumor and its matched metastasis. And loss is more frequent than gain, probably also because we have smaller tissue amount at the metastatic stage. When testing at metastatic stage, using a liquid biopsy will provide a a broader view of tumor heterogeneity, and it will improve the accuracy for treatment selection. When we look between liquid and tissue testing, we expect a modest agreement around 70-83%. And we have to remember that concordance tracks with ctDNA tumor fraction. And we need to have at least 1%, 2% of tumor fraction in the ctDNA. So there is a very important rule. A negative ctDNA should reflex to tissue whenever feasible, and here any tissue that is available. It can be the primary tumor if it's easier to get, but we have to reflex to tissue. So now from where to how, so which method? PCR hotspots is acceptable only if it covers at least the 11 more frequent PIK3CA variants across exon 7, 9, and 20, as it was in SOLAR-1 trial, and it was a PCR assay. We can favor now digital PCR because it's more sensitive if we choose PCR. But it will also always be limited to a certain number of alterations. That's why NGS is preferred where available, because it captures full gen PIK3CA, including additional actionable variants that PCR may miss. And we know that it's up to 15 to 20% of rare PIK3CA variants that can be missed by targeted PCR assays. But also NGS will capture the other actors of the pathway, so AKT1, PTEN alteration, and also other potentially actionable alteration in this group of patients. So then when to test? Well, we have seen it's right now it's when progressing on endocrine therapy with or without prior CD4/6 inhibition. First check ctDNA, then tissue if it's negative. And this is really consistent with the biomarker-driven use in the clinical trials for PIK3CA, AKT1, PTEN altered disease, and also with tissue plasma agreement data. Two important facts. To date, the location of the PIK3CA mutation on the gene does not appear to impact sensitivity to PIK3CA inhibitors, and we observe benefits across all the subgroups of mutation. And finally, I would like to insist on an high impact subgroup and insist on the fact that we don't overlook the double PIK3CA mutations, because they mark an hyper-dependent pathway state, and they often yield the deepest response to PIK3CA alpha inhibitors. That is another reason to perform comprehensive NGS at the metastatic stage. And these doublets are better captured by liquid biopsy, which provide a more comprehensive view of tumor heterogeneity, and they can be missed on tissue testing.
Fantastic, Frederique. And I think some of those details of which mutation, the helical kinase domain, may become more relevant with some of the new agents that Kevin mentioned, and they are currently being investigated. Kevin, just a question for you, just to summarize really, which patients from your experience benefit from treatment with inhibitors of the PI3K AKT pathway?
Yeah, I mean, I think that I think that the way that we describe the studies is actually the order of how I think about this, right? So if you have a patient who has a PIK3CA mutation and they have endocrine resistant disease, I really utilize the triplet. I just think that we see this overall survival advantage, et cetera. And we have data post CDK4/6 inhibition for patients who have more endocrine sensitive tumors. One question that I do get is, what if you have a patient who have endocrine sensitive tumors, and should I give a an agent in this pathway right now, or a CDK4/6 inhibitor, and I tend to give a CDK4/6 inhibitor just given the the benefit that we see. But Peter, you'd made this point of, okay, well, let's continue to see what the power and safety of giving triplets can be in the front line. But I reserve that for endocrine resistant disease. And the other point I just want to make is just, again, with CAPI, the approval is not just for PIK3CA mutations, it's also for AKT mutation, as well as alterations in PTEN.
And I think it's an interesting question because I always find the PI3K AKT pathway is in some tumors and in some patients, therefore, a clear driver of resistance, whereas in other patients, it doesn't seem to be the major driver of resistance. And I think what you're saying, Kevin, makes to me a lot of sense, is in patients where I already see some signs of resistance, it may be that pathway driving it. Whereas, for example, if you have patients who respond for a very, very long time to a CDK4/6 inhibitor and had a PIK3CA mutation right from the beginning, but then develop an ESR1 mutation, the PIK3CA mutation may not actually be the driver of resistance at that point in time. Another element I found really interesting in the first line triplet trial you mentioned is how poor the outcome is for patients in this risk group and with just the standard doublet, but also how almost dramatically we can change this. And one of the points that I think we had because of time in the data set is the response rates. If you look at the response rate of those patients, they reach what we can achieve with chemotherapy or even ADCs in that setting. It just shows if you identify the right pathway and treat the right patient for that, we can achieve a fantastic responses. Now, there's and Frédérique mentioned that when she went through the testing, there's obviously a group of patients who have both ESR1 mutations and mutations in PIK3CA or the PI3K AKT pathway. What do you do with those patients?
And I think this is like where we are moment in time. I do think that one of the concerns we have is, if you have a Y537S mutation, how responsive is it going to really be to fulvestrant if you're thinking of like fulvestrant plus CAPI, for instance? There are some data about, with elacestrant, for instance, where, in smaller series of combining with either everolimus or capivasertib, though, those are not approved combinations and not included in guidelines, including NCCN guidelines. One thing that I will also say, though, referencing NCCN guidelines, at least in terms of like within the US, is that a few weeks ago, there was a change in terms of, a footnote mentioning imlunestrant plus abemaciclib. And so in EMBER-3, which was a study of IMLU versus physician choice endocrine therapy versus the doublet of IMLU plus abema. And in the patients who had co-alterations who received the doublet actually had quite a nice progression-free survival. It was a small subset of patients, but that was intriguing to me.
Brilliant. And you mentioned this when you went through the eligibility criteria. HbA1c is obviously an important factor when we select patients for these treatments. Can you just elaborate briefly on that?
Yeah, I mean, there were different eligibility, and I do check hemoglobin A1C. I suspect as compared to the UK and then also to France, not our patients tend to have high hemoglobin A1Cs, at least where I treat in the Southeast in the US. And so it's not a complete strict cutoff, but one I will say, if I have a patient who's insulin dependent, I get concerned about utilizing these agents. But I do check hemoglobin A1C, and I might monitor a patient a little bit more closely if the hemoglobin A1C was a little bit higher than what we had seen in terms of eligibility on the study.
And can you talk me, again, you mentioned some of that already, but can you just talk me through what's going through your mind when you're in clinic with a patient and you need to choose which of the inhibitors for PI3K or AKT, and how do you select at the moment?
Yeah, I mean, if this is a patient where I'm not thinking about a novel 120, and this is a patient who's had a tumor that has progressed on CDK4/6 inhibitor, I would say I really am utilizing at this moment capivasertib. The side effect profile with alpelisib has made it very challenging to manage the hyperglycemia and the rash. And so when I'm utilizing an agent in that setting, it tends to be with capi.
Brilliant. And I think unfortunately, we're already coming to the end of this program. It would be really great for you to If you could summarize maybe in a couple of sentences what your key takeaways are, maybe start with you, Frederic, and then we come back to Kevin.
Okay. So my message will be about testing. Test smart, right time, right sample, right method. So start with liquid biopsy, use NGS whenever possible, reflex to tissue after a negative ctDNA, and flag the double PIK3CA as potential super responders.
And Kevin.
Yeah, 2 points. One, when we originally saw the data with triplets, we were asking as a community, is it really worth giving three drugs to help keep disease under control or to have a response? And I think we've clearly seen that for some patients with endocrine resistant disease from Anava 120. And then to forecast where the field, I think, is going is with these even more selective agents.
Brilliant. Thank you very much. And I just, as we talk about takeaways, I also want to mention there is a clinician pocket guide associated with this program. And obviously you're all welcome to download this. Now we have come to the end of the program. I would like to thank you both, Frederic, Kevin, really for a great discussion. I would also, all of you out there, thank you for participating in this activity. Please continue to answer the questions that follow and complete the evaluation.